Hi, I'm Dr. Malati, working as a professor in Triple M College of Nursing. In this video, I'm going to discuss about high-risk pregnancy, which focuses on assessment, screening, and management. Objectives are definition, aims, identification of high-risk cases, history collection, diagnostic test, assessment of fetal and maternal well-being during antepartum, intrapartum, and postpartum, management, summary, and conclusion. Definition for high-risk pregnancy. It is defined as one in which complicated by factor or factors that adversely affects the pregnancy outcome for maternal or perinatal or both. So this is the definition which has been taken in Datta. Aims of screening high-risk pregnancy. The aims are to reduce the maternal mortality and morbidity, to ensure the awareness of healthcare professionals, to allow the parents or a couple to decide correctly about the treatment procedures, to allow the parents to prepare themselves, to allow the possibility of intrauterine therapy, referring the high-risk mother, take appropriate measures to prevent the complications. Screening of high-risk cases. Screening of high-risk pregnancy can be done through history collection, examination, and diagnostic test. First is history collection. Under history collection, first and foremost is maternal age. So pregnancy below the age group of 16 or above the age group of 30 years is considered as a high-risk pregnancy. Then the pregnancy following a long period of infertility treatment and after the induction of ovulation is considered as a high-risk pregnancy. So the safest period for a woman to get pregnant is between 20 to 29 years. Reproductive history. Second and third pregnancy after a normal first delivery carries the low risk. Then 2 or more previous abortions or previous induced abortion is considered as high risk. Then previous stillbirth, neonatal death or birth of babies with congenital abnormalities, previous preterm labor or birth of a IUGR or macrosomy baby are considered as a high risk pregnancy under reproductive history. Then grand multipara, which is nothing but the woman has given birth for more than, or a woman has become pregnant for more than 5 times. Then previous cesarean section, or if a woman has undergone any hysterectomy procedure. Then the woman has developed any third stage abnormalities such as postpartum hemorrhage. Then previous history of infant with Rh isoimmunization or ABO compatibility or considered as a high risk. Next is medical disorders during pregnancy, which is nothing but the woman develops any kind of medical conditions during pregnancy, or else prior to the pregnancy some women have a few disorders such as thyroid disorders, cardiac disorders, psychiatric illness, epilepsy, renal disease and pulmonary disease. All these are not related to the pregnancy. The woman is diagnosed earlier before the pregnancy. If a woman having all these kind of medical disorders and if she is on treatment for all these medical conditions, again it is considered as a high risk pregnancy. Then other medical disorders such as viral hepatitis, preeclampsia, eclampsia, anemia, infections during pregnancy like malaria, HIV, torch are considered as a high risk. Next, surgical history. If a woman has undergone a surgery, which means repairing of vesico-vaginal fistula, repair of complete perineal tear, repair of stress incontinence, myomectomy. All these are the procedure which she has undergone earlier prior to the current pregnancy, considered as a high risk. Coming on to the family history, first is socioeconomic status. Low socioeconomic status may have higher incidence of anemia due to poor intake of food, which is related to iron rich. Then preterm labor, growth retarded babies are the complications may arise during the pregnancy, which means the current pregnancy due to the low socioeconomic status. Then family history. If there is a family history of diabetes mellitus, hypertension, multiple pregnancy and congenital malformation are considered as a high risk pregnancy. That's all about the history collection. Moving on to the examination. So the second method to screen the high risk pregnancy is examination under this general physical examination. Height. The woman should be below 150, means a woman should be below or equal to 150 centimeter. In our country, below 145 centimeter is considered as a high risk. Then weight, overweight or underweight. High blood pressure, anemia, cardiac or pulmonary diseases, orthopedic problems, which is related to the pelvis. Next, pelvic examination, uterine size. If it is disproportionately smaller or bigger, genital prolapse, laceration or dilatation of the cervix before the onset of labor, then associated tumors in the reproductive tract, pelvic inadequacy are considered as a high risk for the current pregnancy. Coming on to the third method, that is diagnostic test. So we can screen the mother through blood test, down screening, antenatal assessment of fetal well-being. Assessment of maternal and fetal well-being. So this can be done on each antenatal visit after the registration. You can able to, healthcare professionals can able to screen the mother to rule out the high risk pregnancy. Maternal complications should be looked for and treated if it is necessary. So we have discussed what are the medical conditions. So if anything has been noticed, means that has to be treated during this current pregnancy. After the initial visit, the cases should be reassessed at each antenatal visit to detect any abnormality that might have arisen later. Antenatal fetal monitoring. So what are the areas where we have to look into it? If you see cases with uteroplacental insufficiency, IUGR, a mother has developed the hypertension, antepartum hemorrhage, whether there is any bleeding during pregnancy, prolonged pregnancy, a woman has completed 40 weeks, and the maternal age less than 15 years or more than 30 years. All these areas we have to look into it to rule out the high risk pregnancy. Other antepartum fetal monitoring are previous stillbirth, multiple pregnancy, diabetes mellitus, isoimmunization in pregnancy, polyhydramnios and oligohydramnios. So we are supposed to advise the women to do a USG in all 3 trimesters to rule out this hydramnios. Amniotic fluid index level has to be looked into it. Then hematological disorders during pregnancy are considered as a high risk during current pregnancy. Then coming on to the intrapartum period, patients having no antenatal care. So some women they will not come for the antenatal checkup at all. They will come straightly for delivery process. In such cases, we will not have any history related to that mother. So that is considered as a high risk. Then anemia. Then if a mother has developed BP, which may lead to preeclampsia or eclampsia, premature or prolonged rupture of membrane, amnionitis, meconium stain like a abnormal presentation and position, disproportion floating head in labor. So all these cases we have to look into it, and immediately the mother should be shifted for the cesarean section. Other intrapartum complications are multiple pregnancy, premature labor, abnormal fetal heart rate, bradycardia and tachycardia. Prolonged or obstructed labor may be due to CPD. Ruptured uterus happens mainly due to the previous frequent cesarean section. Induction or acceleration of labor. All these things we have to look into it to rule out the high risk pregnancy, and appropriate treatment should be started as early as possible. Certain other complications also may arise during the labor process: intrapartum fetal distress, delivery under GA, difficult forceps or breech delivery. Sometimes all the other things will be favorable to make a woman to undergo a normal process. With the help of instruments, we can able to deliver it. Suppose if you are using the forceps and making a woman to undergo a normal vaginal delivery, sometimes it will give you favorable, or else it may also lead to failed forceps also. In such situations, emergently we have to shift the mother to the cesarean section. Then PPH or retained placenta. So PPH can be ruled out first and foremost immediately after delivery of the placenta. Check the placental, which means we are supposed to do the placental examination and check for any missing cotyledons. If it is so, that time itself we can able to treat the PPH. Then postpartum complications are PPH, retained placenta, shock or inversion or sepsis. So PPH, as you all know, it's a bleeding from or into the genital tract. Loss more than 1000 ml of blood may lead to a PPH. Sometimes it may lead to shock also. And if the retained bits it's not noticed, means can lead to sepsis also. So these things are considered as a high risk during postnatal period. Coming on to the neonates, categories of neonates are at high risk: respiratory distress syndrome, hypoglycemia, fetal infarction, persistent cyanosis, anemia. Then major congenital abnormalities, convulsions are considered as a high risk neonates, where the neonates should get treated in the NICU. Other neonatal high risk cases are jaundice, hemorrhagic diathesis, Apgar score less than 7, birth weight less than 2500 grams or more than 4 kg are considered as a high risk neonates. Management of high risk cases. High risk cases should be identified and we have to give a treatment during the antenatal period, intranatal and neonatal care. Cases having a previous unsuccessful pregnancy should be seen and investigated before another conception occurs. Then investigations like hysterography, hysteroscopy, laparoscopy or transvaginal ultrasonography should be performed to rule out the Mullerian abnormality. Then, complete investigations for hypertension, diabetes, kidney disease, thyroid disorders should be undertaken and proper treatment instituted in the non-pregnant state. Then the main thing is sexually transmitted diseases should be treated before embarking on another pregnancies. Then cervical tears should also be repaired in the non-pregnant state itself. Then serology for toxoplasma, IgG, IgM and anti-phospholipid antibodies should be done and it should be corrected appropriately when found positive. And the women should be recommended to take folic acid 4 mg per day during the pre-pregnant state itself, and it should be continued throughout the pregnancy. Early in pregnancy and after the initial clinical examination, routine and special laboratory investigation should be undertaken like HIV, HPS, AG. Necessary advices should be given regarding the diet, activities, the rest, how much the woman should take during pregnancy, what kind of activity she can carry, and the medicines whichever she is taking currently. Management during labor. Elective cesarean section is necessary in a high risk cases. If not, we can make a woman to undergo a normal vaginal delivery. If it is not happens means with the help of instrumental delivery. That also if it leads to failed means we can shift the mother for the emergency CS. Some cases may need induction of labor after 37 to 38 complete weeks of gestations. Those cases who go into labor spontaneously or after induction need close monitoring during labor for the assessment of progress of labor or for any evidence of the fetal hypoxia. Condition of the fetus can also be assessed during the labor process, which is nothing but FHR monitoring, passage of meconium in the liquor, examination of the fetal scalp blood for pH values. If there is any evidence of fetal anoxia during the first stage or there is failure to progress, cesarean section is necessary. Summary. High-risk pregnancy refers to a condition in which the mother, fetus or both are at the increased risk of complications during pregnancy, childbirth or during the postpartum period. Risk factors may be maternal, fetal or the combination of both. So maternal such as anemia, hypertension, diabetes, heart disease, advanced maternal age. For fetal, congenital anomalies, intrauterine growth restrictions, multiple gestation. Sometimes risk factors may also due to placental and obstetrics in origin like placenta previa, abruptio placenta, previous cesarean section. So early identification through antenatal screening, regular monitoring and appropriate investigation is essential for preventing adverse outcomes. Here, nurses plays a vital role in assessment, health education, emotional support, early detection of complications, timely referral and coordinated care throughout the pregnancy and childbirth. Conclusion. High-risk pregnancy remains a major challenge in maternal and neonatal health, but can be effectively managed with early diagnosis, multidisciplinary care, and skilled nursing interventions. The obstetrics and gynecology nurse acts as a key caregiver in ensuring maternal and fetal safety by providing continuous monitoring, promoting adherence to treatment, educating the mothers about warning signs, and supporting the families emotionally and psychologically. Strengthening antenatal care services and empowering the nurses with updated knowledge and skills can significantly reduce the maternal and perinatal morbidity and mortality. Ultimately, we can able to improve the pregnancy outcomes and quality of care. Thank you.